The lady at the same horizontal table, she asked me, and she something like this, not
We're gonna have sandwiches for after, so they'll
so I
have,
can help you.
I hope they really sponsor just for that.
they will have, we'll have sandwiches.
So she has to wait.
It'll be here when,
Oh, for the first?
yeah.
Oh,
We'll have
wait
it in
until like
between.
11.
Yeah, it'll
Oh,
be,
okay,
yeah.
okay. Before 11, or between.
It'll probably be here
Deanna,
around
it'll be
11.
before they leave.
Yeah.
It'll be before they leave. I don't know
Okay,
exactly
I will
what time. Okay, thank you.
Thank you.
I didn't ask. Good morning, everybody. Thank you all for joining us today for our semi-annual in-service day. I hope you had a chance to get started on our self-study tests. I do want to stay on time because we do have a full agenda this morning. So just to make sure that we keep you guys on time, let's go ahead and start. If you guys could please take a look at the packet of paperwork that you picked up when you signed in. So if everyone could look at this, please complete your annual health screen form. But right now, we're going to move to the self-study tests. And the first test is safety and accident prevention. So if everyone could please turn the page to the test that says safety and accident prevention.
Первое, пожалуйста, заполните сведения о вашем здоровье, там туберкулез и прочее. А вторая часть, мы сейчас переходим к тесту. То есть тест идет следующий по заданию. Так что мы вам будем говорить правильные ответы. Будьте внимательны. И также все ответы вот у нас на экране. Пожалуйста, кто не успел, не услышал, можете прочитать и спросить также.
I'm going to go through the answers for everybody, but also if you want to follow along, they are up here on the screen. So I will read them out to you. Safety and accident prevention, number 1 is B as in boy. Number 2 is C as in cat. Number 3 is A as in apple. Number 4 is D as in dog. Number 5, you were to check all that applies, so it's A, B, C, and D. So for number 5, it is A, B, C, and D. Number 6 is A as in apple. Number 7 is B as in boy. Again, please refer up here to the answers. Does anybody need me to repeat those? Okay. And let's move on then to the test for Medicare and Medicaid fraud. So if you could turn the page, it's Medicare and Medicaid fraud, waste, and abuse prevention. Number 1 is C as in cat. Number 2 is B as in boy. Number 3 is B as in boy. Number 4 is B as in boy. Number 5 is also B as in boy. Number 6, again, you were to check all that apply. So this is A, B, and D. Number 6, again, I'll just repeat that. A, B, and D. And number 7 is D, as in dog. And I shall move on. If anybody needs help or needs me to repeat things, we can discuss that later, because again, I just want to remain on time. All right, let's move now to the test for needs and rights of the elderly. We're going to move to the next test that says needs and rights of the elderly. Number 1 is C as in cat. Number 2 is D as in dog. Number 3 is B as in boy. Number 4 is A as in apple. Number 5 is D as in dog. Number 6 is C as in cat. And number 7 is B as in boy. And then we shall move to the final test, which is advanced directives. So let's move to the final test is advanced directives. Number 1 is B as in boy. Number 2 is C as in cat. Number 3 is D as in dog. Number 4 is A as in apple. Number 5 is C as in cat. Number 6 is A as in apple. And number 7 is D as in dog. Okay, so again, please review the tests. Please make sure your name is at the top of each page and today's date. Today's date is May 8th, 25. On the health screen form, it's two-sided. Please make sure you complete the front and the back of the health screen form. If anybody needs assistance, you can let us know. When you're done, we're going to collect these tests up. So if you could just put them towards the center of your table and we'll walk around and pick them up. And if you need more time, that's fine too. Okay. Any questions about the self-study tests? No questions? All right. Well, then we're going to move on. Our presenter, Charlene Chen Young, is going to be here to present to you taking and recording vital signs. And she will be in just one moment. Yeah. Okay, I don't want everybody to wait, so let me go ahead and I'll start with my presentation.
I will go.
All right, so what I'm going to talk to you guys about today is bathing alternatives. So it's things that are beyond the bath. So let me just kind of read to you a scenario that, and you guys can tell me if this sounds familiar. So Marcia had only worked as a CNA for 1 month, but she was already beginning to dread the daily battle she had with her clients, and it was about bathing. She had orders from her supervisor to bathe the clients twice a week, and she had a schedule to keep. She tried her best to design a route that made it all possible, but every day there was at least one client on her schedule that would derail the whole plan. On Monday, Mr. Cheney saw her coming with a stack of towels and barricaded himself in the closet. On Tuesday, Ms. Rose screamed, "Leave me alone." On Wednesday, Mr. Robertson refused to wake up and get out of bed. And on Thursday, Mrs. Ham grabbed and pinched Marcia all the way to the bathroom, and then she pulled Marcia's hair. On Friday, Marcia was exhausted. She needed a better way to be able to encourage and get her patients or her clients in the bath. Does that sound familiar? Has that ever happened? Has anybody here ever had a week like that? Where everyone's giving you a hard time and nobody wants to get in the bath? Usually I think we see this in the winter when it's cold out and people just don't want to get in the bath. So whether you're new or seasoned, everybody has had those clients that are afraid to get in the bath, or they just don't want to, or it's cold, or, there's a myriad of reasons. A lot of times people, with Alzheimer's or dementia have problems or are afraid to get into the bath. And there's no one approach, but there are different alternatives that you can use and best practices that are going to work with some better than others. So we're going to talk about some client-centered approaches. So first, let's look at why is bathing so important. I think that we generally know, but let's look at from an elderly person's perspective. Of course, it removes dead skin cells. It cools, refreshes, and relaxes you. It controls body odor. I mean, those are kind of obvious, but it also is going to prevent infection. Very important that people overlook. It provides an opportunity for them to exercise, because a lot of times people just sit a lot or they're immobile, and this gives people an opportunity to actually get up and exercise and to have some bit of independence. It will stimulate circulation. How many of your clients, feel like they're always cold? A big reason for that is because their circulation is poor. When you get up, when you're in the shower, when you're moving, or somebody's, helping you rub your legs or your arms, that's going to stimulate that circulation. And ultimately, it also helps to prevent the skin breakdown. It's going to help prevent those skin ulcers or sores because the circulation is improved and because the skin is clean. So I think you guys could tell me better than I could tell you. What are some barriers, or what are some things, and I'll ask you and you guys can just shout out, what are some reasons why your clients don't want a bath? They could have a rash, it hurts. There might be some, I heard somebody over here say humiliation. It's embarrassing. How many times have you ever had somebody bathe you? Probably not very frequently. It's not very comfortable. What are some other reasons? Well, some people have fatigue. They're just too tired. If you've had the flu or COVID, do you feel like getting in the shower? Not really. You want to stay in bed. Some people are actually afraid of water, and you see this a little bit more and more with people with Alzheimer's or dementia because it's scary. It's unfamiliar. Embarrassment, physical discomfort or pain, or also if it's too cold or hot. Fear of falling. That's a very real fear for our patients who don't feel very steady on their feet. They're afraid that they're going to fall in the shower or the tub. They're confused, forgetful. Again, the humiliation of not being independent. And then also just some poor lighting, safety concerns. So let's look at ways that we can make it patient or client centered. Make use of available information. YouTube is a wonderful resource, okay? I've gotten to where anytime I don't know how to do something, I'll say, let me see if there's a YouTube tutorial. Do your own research. What time with the client, ask them, what time do you usually wake up in the morning? What's your morning routine? Do you like breakfast right away, or do you like to shower in the morning? Some people prefer only to shower in the morning. Some people prefer only to shower at night. And I think it's probably about 50-50, so that's an important factor. If you're trying to give someone a shower in the morning who's only ever showered at night, they're going to be confused and they're not going to feel right. What time do you go to bed? What does your bedtime routine look like? And do you want a shower daily, or do you just want to freshen up in between showers or baths? A lot of our clients, again, they're not super active. They're not, out there sweating and doing work and things like that. So it's not really necessary to get them in a full shower every single day. So those are things that are important to remember. So let's look at some alternatives to bathing. One is going to be a towel bath. So what does this look like? It's essentially, excuse me, you're going to place one bath blanket or towel under the person, and that's to protect like bed linens and stuff. This is going to be more common for somebody who might be in bed bound or chair bound. You would undress the client, but keep them covered with those, the towel or the bed linen, the areas that you are not washing at that immediate time. So there's no need for somebody to be sitting there naked. It's cold. They're not having water directly on them. It's going to be cold. So just keep them covered except for the area that you're washing at that exact time. Make sure that the water or the towel is not too drippy. You would wring out very well the excess water, moisture from the towel. Make sure that the feet and the lower legs are going to be covered with a warm, moist towel. Again, you can cover them with these more moist towels. And then you're going to just start by massaging or patting gently the towel. You're essentially covering them with a warm, moist towel, not super wet, and then just kind of patting them down with that. You'll wash the backs of the legs, the backs of the knees, wash the face, neck, and ears. I think that we all know you start from the cleanest to the dirtiest. So it's typically head to toe, not toe to head. You don't want to have your feet washed first before your face. But you can use different towels and washcloths for each area of the bath. If the patient is in bed, then you would turn from one side to the other. And then again, make sure that if you are using this method, there's really no need to put them in an actual shower for rinsing, because you've been kind of rinsing them along the way with a warm, wet towel, or warm, moist towel the entire time that you've been rinsing or washing them. So once the whole body is washed, then you would remove all of the wet towels and then cover them with dry towels. Does this create a little bit more laundry? Sure, but it's one load of towels. It's not, it's not going to be a week's worth of laundry for you. Now we're going to look at the recliner bath. How many of your clients, they really don't even sleep in a bed. They're constantly in a recliner. And a lot of times this is for comfort. Some people have issues with their legs, where it's better for them to have their legs elevated. Sometimes it's just not comfortable for them to be laying flat in a bed. So they are constantly in a recliner. So with this, you'll just take a basin of warm water and no rinse soap. No rinse soap is going to be important, because if you use regular bath soaps and stuff, you do have to rinse it, or else it'll dry the skin out a lot, and it would also leave like a sticky film on it. So you pat each part of the body, washed, and you can also use like an incontinence pad, those that are a little bit more absorbent. You can help wash them with that. And next time they use the restroom or the bathroom, that's when you can wash their bottom and perineal area. So you're not having to do it all at once. The commode bath is very similar. And again, you do have to be sensitive to people's feelings, because it is going to be a little bit embarrassing sometimes. I know that when I have worked as an aide in my past life, this was one that we did have to use with people, because it was very difficult, for them to have so many different movements. So you would put them on the commode and then begin their bath. So again, you would fill a basin with the warm water, no rinse soap, massage the back with the washcloth. Most people, not everybody, but a lot of people do like that gentle touch of a soft massage on their back. It just feels good, and a lot of times our clients, they may not have that a lot. So, that's something that can give them a little treat. Continue to speak in gentle tones, talk about everything except bathing. And this is important for your clients that may have Alzheimer's or dementia because they're nervous. You know, they don't know who you are, usually, and they're not really sure why they're sitting here naked on a commode and why you're in their room. I mean, that's pretty scary to think about. So just talk to them about things other than the bath because you don't want them to be more nervous. Wash the legs. And then have the client stand safely so you can wash again their bottom and perineal area. The wet wipe bath, sometimes I think you've probably had to use this sometimes for children, especially when, you know, the disposable wet wipes. You want to make sure that they are the sensitive skin ones because there are some that are harsh with alcohol and things like that. Those are really going to dry out the skin, so you want to make sure that you're using the sensitive skin wet wipes. Some people don't want this method because it can get a little expensive. You know, you're using all the wet wipes, and those can be pretty expensive, and they are disposable. I know that they do make wipes warmers. You know, usually you find those in a diaper or a baby aisle where the wipes can actually be warmed up to make it a little more comfortable on the skin. So you would use the wipes to clean the entire body area, including the underarms and perineal. It's very important not to flush wipes down the toilet. Those will clog up the toilet. Very, very important. You do not flush wipes down the toilet. But then avoid using the wet wipes on the face. Usually a washcloth is going to be better on the face because even the alcohol-free wipes still do have some agents that are drying to the skin. So you just want to be careful with that. And most of the time, just a warm, wet washcloth on the face is sufficient. This is one that I found to be kind of interesting. And it is just going to depend on your client's situation and your client's comfort. But they call it the 5-day bath. And these would be more for clients that you're going to be seeing each day. So first, you're going to wash your client's face each day and wash his or her bottom and perineal area after each BM. So those are important. You're not going to let those go, you know, a week. But then each day, you can spend less than 5 minutes on one other area. So this is an example. You're going to divide the body into 5 sections and wash one each day. For example, Monday, wash hair. A lot of older people do not wash their hair every day. So once a week can be sufficient for hair washing. So Monday, you wash the hair. Tuesday, upper body, let's say arms and chest. Wednesday, wash their back. Thursday, lower body, including legs. And Friday, their feet. So each day you just take one part of the body, and that way it's really not a traumatic bath. They don't have to be completely, you know, naked at the same time. And it's something that just kind of separates the day and gets them moving each day as well. A few useful products that are going to be very helpful for the safety and convenience of the bath. Very important for those clients that are unsteady, for grab bars in the shower or near the toilet if they have that accessible. Those are very important to have so that they can properly hold on to the grab bar. A heated towel bar, that's just kind of a nice little treat, especially if it's during the cold weather months, so that the towel, when they get it, it is warmed up for them. Safe seating. Many clients need a shower chair, or it would be better for them to use a shower chair. These are things that don't have to cost a lot of money. If you buy them new, they can be a little pricey, and unfortunately, most insurances and Medicare and Medicaid don't cover them. However, I know a lot of times you can find them at thrift stores because, you know, when people don't need them anymore, they can consign them, thrift them. Goodwill oftentimes has them, and they're safe and less expensive to use. So those are good places to look for, specifically for shower chairs. Cleansing wipes, like I mentioned earlier, for the wet wipe bath. Baby wipes, as long as you don't flush any of the wipes down the toilet, very important. Rinse-free soap and hair washing products. There's a lot of different no soap or dry shampoos that are out now, depending on your client's hair. Some of them work better than others. So those are things that you can use without having to wet their entire head down. So just some final thoughts, and then I want to open it up to you guys for some additional ideas. Give choices to your client. There's no one way to give a bath. Okay, it doesn't mean that every single person has the exact same shower every day. Give them choices. Give your client a role. You're not going to just be in there. We're dealing with adults, and it is very important for them to maintain their independence and for them to not have that embarrassment while you're bathing them. So give them a role. Sometimes it's good to distract them with a television show. I saw one that was called an I Love Lucy bath. And what that meant was the client loved the TV show I Love Lucy. So the employee just put it on a laptop or an iPad for the client to watch while they're taking the bath so that it distracted them and they were able to focus on the TV show rather than the bath. Always protect your client's dignity and privacy. Help her feel less vulnerable by covering with a blanket while undressing. Okay, keep it on and cover it up. Because again, it's not only for the temperature being cold or uncomfortable, it's also from the exposure and embarrassment. Know what your client's preferences are. Try to simplify the process. It does not have to be complicated. And if a client is adamant about not getting a bath that day, that's also okay. But in those cases, if your client is adamant every day about not having a bath or any kind of help getting cleaned up, those are things that you probably need to report to your supervisor, your coordinators, because then we'll have to try and get a little bit creative and assist them just to make sure that they are clean. Give easy one-step directions and keep the instructions simple, especially with somebody that might have Alzheimer's or dementia. If you give someone 3 steps, it's going to be way too overwhelming. It's going to be way too confusing, and they're going to be very frustrated. So if you give 1 step at a time, step into the shower, put your hand on the bar, sit on the chair, each step individual so that they can actually accomplish that step and everything is going to move a little bit easier for everybody. And you can even demonstrate the steps, step into the shower, or sit on the chair, because sometimes even the language that you're saying, it could be confusing that particular day for that individual. So now I wanted to ask you first if anybody had questions, but also I'm interested to know some things that you guys may have been able to do successfully to have a client be able to get a shower or get clean. So first, did anybody have any questions? Yes, I see a question back here. So the question was, what if they are constantly refusing showers and baths? Is that the question? I think the first step would be to try some alternative. Maybe that 5-day approach would work best with them, where you're just taking one part of the body each day so that they're not feeling like I have to have a shower today. If that doesn't work, you can try some of the other approaches. Ask them what their favorite TV show is. See, okay, I have it on here in the bathroom. Do you want to come while we take a bath? Do you want to watch the show? You can give different ideas, different alternatives, because like I said, there are going to be clients who just don't want a shower or they don't feel like they need a shower. And sometimes you can smell that they do need a shower. And you have to be sensitive to the reasons for that. But I would definitely try one of the alternatives to the bath. Are there any other questions? Has anybody had any creative ideas or creative solutions to bathing somebody who was resistant? Stand up or raise your hand because I can't see if you, no? Has anybody tried any of these approaches? No? All right. Well, if we don't have any other questions or comments, stand up. I can't hear you. Okay. Come up here, talk into the microphone so everyone can hear you. We have a helpful hint or suggestion, something that's worked before.
Hello. Hi. Yeah, I tried the I tried your example, but I take care of my son. But I tried putting on the TV shows that he liked to distract him because he has a brain injury, so he gets very agitated. I said I tried her example on my son because I noticed that he gets agitated at times. So he gets fussy because of his situation. So it is embarrassing for him to take a bath on his mom, for him not to have clothes on and stuff like that. So sometimes I'll turn on a TV show or I'll turn on music and he likes gospel music. So that calms him down. So when I put on a gospel music, or other music, he'll start dancing. So I try to, let him get serious. I'm like, we gotta take a bath and not be so happy dancing too as well. But but that does calm him down and it makes him wanna, it takes his mind off of looking at all that. And then I'll put a towel right here so he can be more comfortable. But it takes his mind off of it. It makes him wanna, think about, yeah, I need to do this. And I talk him through it too as well. I'll be like, as other people gonna come here, you need to smell good. You don't want people to come in here and and I just try to bribe them. So all of things does work. Yeah.
Thank you for sharing that. That's a great example. And a lot of times too, it can be less comfortable receiving care. I know a lot of you are taking care of relatives, your moms, your dads, your aunt, your sister, your child. And it could be a lot less comfortable receiving care from a relative than a stranger, as strange as that may sound. So just be aware of that too. As a mother, I don't want my kids to have to give me a bath. That was my job to give them a bath, so that's something, just kind of be aware of it and sensitive to that too. Okay. Well, thank you guys very much for your time. We are going to move on to our next presentation. All right, so I am going to give the mic to Jocelyn Douglas. Jocelyn is Jocelyn's our RN supervisor, and Jocelyn is going to talk to you guys today about nutrition for your home care clients. So please give her your undivided attention. Thank you, Jocelyn.
Good morning, everyone. How's everyone doing this morning? Good, good. So I'm going to start with talking about nutrition and meal preparation for your home care clients. Okay, so one of the most important jobs as a home care worker is going to be preparing food for your clients. There's a great deal to know about this, and unfortunately, even though much of this information, which we should all be aware of, the reality is that many people tend not to know this information. Here's what you need to know. The basics of nutrition. Let's begin with carbohydrates. Under the USDA food pyramid, complex carbohydrates such as whole fruits and vegetables, whole grains, and similar products should make up the bulk of the diet for most of your home care patients. The amounts will vary depending on the specific diagnosis of your patients and the doctor's instructions. Protein. The second building block of nutritive food is made up of protein. Protein includes most kinds of non-fatty animal flesh, like lean beef, ham, and venison, as well as most fish, poultry, and certain kinds of vegetable products. Under the USDA food pyramid, these should be more limited in the diet of your home health care patients. Fat. Finally, fat is the third building block of nutritive food. There are a large number of kinds of fats, including saturated fats, polyunsaturated fats, and monounsaturated fats, to name just a few. In most cases, fat is recommended to be limited as well in the diet of your home health care patients. There are, however, exceptions for certain kinds of fat, which can be beneficial. It's important to consult with the doctor if you're not sure which kinds of fats that are allowed for your patient. Okay, non-nutritive foods. Nutritive means that a food has calories. Non-nutritive foods include water. It is virtually important to functioning of our bodies. However, it does not have any calories in its pure form. Minerals, such as zinc and calcium. Then you have vitamins, like vitamin A, vitamin B, etc. Many spices, even though they serve an important function in making food taste good, and in limited amounts are necessary for proper functioning of our bodies. Salts, for example, is important to the human body, but only in moderation. Variety is key. The single most important thing you can do for your clients is to ensure that they get a variety of foods into their diet, generally based around the food pyramid. This is the USDA Guide to Healthy Eating. In 2011, the USDA updated their food pyramid and replaced it with My Plate. This new framework emphasizes a balanced approach to eating. The USDA main recommendations for eating healthy are having a well balance of fruits, grains, vegetables, protein, and dairy. The USDA Guide to Healthy Eating. This includes balancing calories. Enjoy your food, but eat less. Avoid oversized portions. And use exercise to offset your intake. Foods to increase. Make half your plate, make half your plate fruits and vegetables. Make at least half your grains whole grains. And switch to fat-free or low-fat 1% milk. Foods to reduce. Compare sodium in foods like soup, bread, and frozen meals, and choose the foods with lower numbers. And drink water instead of sugary drinks. Now, there are challenges to eating healthy, which could include dietary restrictions, the cost issues, and personal taste. Now, how can the PSA help? Well, with shopping, you can help. Some seniors find it difficult to get to the store. Driving themselves may become tiring and dangerous, and suitable and timely transportation may also be frustrating to arrange. Even just carrying groceries in from the trunk of a vehicle and stocking them in the fridge and cupboards may prove too much for some older adults. Feeding. Home care workers can choose and prepare meals that make eating easier for older adults that need additional help. In addition to physically helping adults eat, preparing foods soft like breads, dips, stews, and soups are all great alternatives to more elaborate and hard to eat meals. Preparing food. Special diet restrictions and regimens advised by doctors or other medical professionals can be daunting and hard to follow. Seniors may not have the skills or experience to prepare foods in new and different ways to meet their changing dietary needs. Preparing food. When preparing food for your home care clients, it's important to ensure that you follow a number of safety precautions as well as maintaining healthy food choices. This means that you should use whole foods when possible, avoid frying and convenience foods, and find out how the client likes their food prepared. What to watch for. As a home care worker, it's part of your job to watch carefully what your clients eat. If they are showing a pattern of eating less than they usually do, it may be a sign of a problem which should be reported to your supervisor. Best practices. Store fresh milk, eggs, and the like in the refrigerator. Meat products should be stored on the bottom shelf of the refrigerator to avoid the possibility of contamination from drips. Fresh fruit and vegetables need not to be refrigerated until they turn ripe. Be sensitive to pricing and use coupons when possible to save your home health care client on their grocery bills. And that concludes my presentation. Thank you. Okay, next I'll be handing the mic over to Ms. Charlene, who is our clinician educator.
Morning, everybody. Thanks for coming. Okay, so today we're going to talk a little bit about vital signs. Can you tell me the vital signs? Mm-hmm. Respiration, blood pressure, temperature, and the pulse. Those are the four main ones. So blood pressure, temperature, pulse, and the respiration. What do we know about blood pressure? It can be high or low. Okay, that's fair enough. And if it's too high, what do you do? If it's too low, what do you do? Mm-hmm. But what does it mean? What's the definition of blood pressure? When you do somebody's blood pressure, what exactly are you measuring? No? Anybody knows what the blood pressure is? Right, it's a force that we're measuring. We're measuring the force of blood against the inside of your arteries. And it's very important because that force that's hitting against the inside of the artery can damage the artery. It can damage the vein. And it's that damage that's going to lead to medical issues. That's why it has to be normal. So here we're looking at blood pressure. And to measure blood pressure, we use a sphygmomanometer, large word. Does anybody understand what's happening when you're measuring the blood pressure? How many people use a manual blood pressure machine? Where you put it on the arm, you put the stethoscope in your ears, you pump it up. How many of you use a manual? I see one hand, two hands. So everybody use an electronic device, correct? Okay. Now, what does that electronic device do? So the electronic device or the manual, it comes with a cuff. And the cuff goes around the upper arm. Sometimes you can put it on the leg, but mostly we put it on the upper arm. When you're putting the cuff on a patient, what are some of the precautions you're supposed to take? How the arm is positioned, that's one, but the cuff itself. Correct. So the cuff has a different size. So the size cuff you use for an adult, you wouldn't use for a child. And the size cuff you use for somebody that's really, really skinny, you wouldn't use on somebody that's really, really large. Because it makes a difference. What else about the cuff? Before you put the cuff around the patient's arm, it should be? That's when you put it on, but before you put the cuff on the arm, it should be deflated. We're supposed to make sure we don't have extra air so that we get accurate readings. So the cuff should be totally deflated before you put it on somebody's arm. When you put it on the arm, should they be able to bend their arm? Yes. So you're going to put 2 fingers above the elbow and make sure that the customer or the client can bend their arm. They should not bend their arm and then the cuff is creasing in the middle. That means it's too low. It's not in the right position. Okay? Now, when you put the cuff on somebody's arm, the machine or the physician or the clinician is listening for something. And what we're listening for is called carrot cough sounds. That's somebody's name. Now, in order to hear or for the machine to detect something, you have to have 2 things. You have to have compression of the artery and you have to have blood flow. Compression and blood flow. So initially, when you inflate the cuff, you inflate it to the point where there's no blood flow. Beyond where that cuff is, there's no blood flow. So that's almost as if you have a garden hose and you stand on it. You put compression on it and there's nothing beyond. You stop the flow. And that's important because when you leave the cuff inflated on somebody's arm, there's no blood flow. So the arm is going to change color. It's going to become very painful and your patient will be uncomfortable. So you never ever leave an inflated cuff on somebody's arm. If the doorbell rings, your cell phone rings, anything else is happening to get your attention, you have to deflate the cuff before you leave the patient. Now, you know that when you start the machine or when you pump it up, you get to a point where there's no blood flow. And at that point, you start to deflate the cuff. As you deflate the cuff, you're going to come to a point where blood just begins to flow. So your foot is on the hose, you gradually lift it up, and the water begins to flow again. At the point the water begins to flow, that's the systolic blood pressure. Typically, the nurse will hear the first lub-dub. The machine will detect the first flow of blood, and it will read what pressure did that happen. That's the systolic, that's the number that goes at the top. As you continue to release the pressure, the flow gets heavier and heavier, and you're going to come to the point where your foot is completely off the hose. So there's 0 compression, but maximum flow. So just before that point, you're going to hear the last lub-dub. The machine is going to detect that last flow. And that's the diastolic. You're going to look at the dial, read off the number, and that's the number you write at the bottom. So the systolic, when the heart contracts, the diastolic, when the heart relaxes. And that's what that diagram is trying to explain to you. No sounds, the artery is sound, the artery is closed. As you release the pressure, you will hear the first lub-dub. That's when the machine detects it. It will read the pressure, or the nurse will actually look at the dial and read the pressure. So the abnormal blood pressure points, if the patient's blood pressure is less than 90/50, that's too low. Or if it's greater than a 180/100, it's too high. And those values must be reported. Can anybody tell me some symptoms your patient may have when the blood pressure is too low? Dizziness is one. Anything else? Lightheadedness? Feeling faint? Feeling weak? They can also lack energy. So these are all signs of a low blood pressure. What are some signs of a high blood pressure? Headaches. What else? Nausea. Swelling of the limbs. That's more when you have heart failure. But when the pressure is high, what else can happen to you? Frequent urine. That's more again with the diuretics in heart failure. You can also feel dizzy. You can collapse. You can have a stroke. Patient may complain that they have tingling in one limb, or they're unable to move a part of their body all of a sudden. So these are things you have to think about. So when you go to see your patients, is it a good idea? Your patient got up, they walked to the door to let you in, they took their walk and they walked back to sit down. Is it a good idea to do their blood pressure immediately? Why not? I can't hear you. It will be high, but why? Because the patient actually exercised. Because for some of those patients, the amount of effort it took them to walk to the door, let you in, walk back and sit down, that's for them exercise. Their pulse goes up, their heart rate goes up, their blood pressure goes up. So you have to give them time to relax. 5-10 minutes before you repeat the blood pressure or before you do the blood pressure. So you do your patient's blood pressure, you get there, you've waited, you're talking with them, you do it and everything is fine. 2 hours later, they're complaining of dizziness, headache. What do? You check their vital signs again. So don't get in the habit of thinking, oh, I just did it 2 hours ago and she was fine. These are static values. These are moment in time values. Because I could be talking to you now and in the next 2 minutes I'm laying here. It means that my vital signs changed, correct? So you always have to check and make sure you can figure out what's going on with the patient. Temperature. Body temperature. The amount of heat in the body, and it's typically measuring the balance between the amount of heat produced and the amount of heat lost by the body. Do we know how the body produces heat? Didn't hear that. It burns calories. Just a natural functioning of your body. When you eat and your body digests food, when your body respires, all of these energy reactions in the body produce heat. Where do you most commonly measure the temperature for your patients? Forehead. That's the most common place nowadays, I guess, with COVID. Under the tongue. Where else? Axilla, under the arm. Forehead, yes, somebody said that. not behind the ear, but if you have a specific, the auricular thermometer, you can test it in the ear. They mostly do that for children though. So the axilla under the arm, the ear, the mouth, and the rectum. I know most people don't do the rectum, and that's also done a lot in babies, and they typically use the mercury thermometer. So the mercury thermometer, you have the bulb at the end. That's the part with the mercury that you place under the patient's tongue. So typically you have to flash until it all goes down. And you place it for 10 minutes. Make sure the armpit is dry. There's no clothing between the arm and the chest. And you wait. Now, typically, most people use a digital thermometer. Does anybody here in the room use a mercury thermometer? Oh, Diane does, okay. And that lady does. So typically, we use a digital thermometer. And how many of you check to make sure that the digital thermometer your patients are using is okay? Does anybody ever check to see what their patient is doing? I had a situation, I think it was about 2 years ago, we had a patient. And the nurse would go and check his temperature. He was diabetic, he had a wound, and he had a fever, 100.5. The nurse told him he had a fever. He said, no, he didn't. He checked it himself, and it was 97.8. Something is wrong with our thermometer. We monitored him. The next time the nurse went, his temperature was 101. And he got into a big argument with the nurse again that something is wrong with her thermometer. She doesn't know what she's doing. He took his temperature and it's 97.8. So the nurse asked him, can I see your thermometer? So when we took out the thermometer and looked at it, can anybody guess what was happening? No. The sticker was still on the thermometer. You know, when you get these thermometers, there's a little sticker over the window, and the sticker has a measurement written on it. He did not take the sticker off. So every time he took his temperature, it was 97.8. So the lesson there is that we also have to check. See what your patients are doing, make sure they're doing it correctly. Because he's trying to help himself. He's checking his temperature. He has a wound. He's diabetic. But he did not check the instrument to make sure that the labels were removed. So it's important that we help and monitor as we take care of our patients. So the digital thermometer, insert it under the tongue. Keep it under the tongue for 5 to 8 minutes. The thermometer usually helps you because it usually beeps when it's ready. So you wait to hear the beep, you take it out, and you read what the patient's temperature is. So normal body temperature for the axillary region, the range is 96.6 to 98.6. In the air, 97.6 to 98.6. Orally, 97.6 to 99.6. And rectal, 98.6 to 100.6. When do we report the temperature? When it's greater than 38 degrees or greater than 100 degrees Fahrenheit. Always report the results. But I also suggest that you should repeat your vitals or whatever result you get that's abnormal before you report it, because you want to make sure it's reproducible. You want to make sure that you're not making an error. Okay, how to take the pulse? How do we take a pulse? Don't all shout at me.
First, look at the clock, see what we started. Then look to see for rise, touch the chest. And put our hands to rise, put our fingers on the regular. Count to 28.
What are you counting? What are you counting?
The beat, how many beats per minute?
Okay. So why were you looking at the chest before? What was the purpose of that step?
See how many, see how it rise like this?
That's the breathing, that's the respiration, right? So the respiration is the breathing and the pulse is different, which is the heart beating. So every time the heart beats, meaning the heart contracts, so it squeezes, and when it squeezes, it sends out a gush of blood. And that gush is what we call the pulse. And that ripple travels along the artery. And that's exactly what you're counting, the pulse. So where do we find this pulse? On the wrist. Does anybody know the name of the pulse or the name of the artery on the wrist? The radial artery, very, very good. So we feel for the pulse in the radial artery. Any other artery, anybody know? The carotid artery, where do you find your carotid artery? In the neck. It's the large artery that supplies your head and neck. Any other artery? Pedal. Any other one? Femoral, very good. We all remember our biology, very, very good. Any other one? Which one do they use when they're checking your blood pressure? Does anybody know the name of that one? The brachial artery. So that's the artery that's right here. So that's why you place the stethoscope over it so you can hear. The radial one is here, the femoral is in the groin, and the carotid is right here. So very good. So any of those arteries you can use to check your patient's pulse. Now, does anybody know which of those arteries are considered peripheral arteries versus central arteries? The radial artery is peripheral and the carotid artery is central. It's a very large artery. So if a patient was losing blood, you may have a patient that's on aspirin or an NSAID and they're having an internal bleeding, GI bleeding. Which pulse is going to disappear first? The peripheral pulse or the central pulse? I hear central over here. Does everybody agree? Which one is going to disappear first? Very good. The peripheral, the one that's furthest away. So if you can't find the patient's peripheral pulse, you go centrally. That's why when you see a lot of these movies and they have somebody laying on the ground bleeding, they're always feeling here. You never see them touching the wrist. Does anybody know why? What's the body trying to do when it eliminates the pulse from the periphery? The body is trying to save your vital organs. It's going to maintain the blood circulation centrally, the brain, the heart, the lungs, and the kidney. That's why your periphery gets cold and clammy, because everything is central to maintain life. So how to take the pulse? You're going to use your watch or clock, as you said. You should have one with a second hand, or if you have the digital one, it has the seconds counting. Find the radial artery. You're going to press lightly until you feel the pulse, and you're going to count the pulse for 1 full minute and record the reading. Why do we count the pulse for 1 full minute? Very good, because your patient may have an irregular heartbeat. You may hear nurses talking among themselves or doctors and they say, oh, I count the pulse for 30 seconds and multiply it by 2, or 15 and multiply it by 4, or 20 and multiply it by 3. You cannot do that when a patient has an irregular pulse because it's beating irregularly. You cannot predict the next pulse. You cannot predict the next heartbeat. So you have to count it for the full minute, the entire 60 seconds, to determine the true number of beats per minute. So can everybody find their radial pulse and check their pulse for me? Can everybody find their radial pulse? Do I use these fingers to check my pulse, or do I use this finger to check my pulse? These fingers. Why do we not use this finger? Strong pulse, so you may be feeling your patient's pulse but counting your own. So you always use these fingers to check the pulse. I need everybody to use these fingers. I see some people using their thumb. You got to use these 2 fingers to find the pulse. You want me to find mine? It's right here. Is everybody convinced that they can feel their pulse? And everybody find their carotid. So you feel for the angle of the jaw, come down and just push in and up. It's supposed to be strong. Should you ever feel somebody's carotid pulse on both sides of their neck at the same time? Why not? No? Why wouldn't you feel both of them at the same time? If you're pressing on both of them at the same time, what are you doing? Not your airway, but you're cutting off blood flow to the head. So what's the abnormal pulse rate? If it's less than 50, it's beating too slow. And if it's less than 110, it's beating too fast. So your patient is tachycardic if it's too fast, or bradycardic if it's too slow. If you had an NFL player in the room and you took their pulse and their pulse was 45, would you worry? Why? In an NFL player, a 25-year-old NFL player with a pulse of 45, you would not worry because they have a much lower resting pulse due to how healthy and fit they are. So athletic persons usually have a lower resting pulse than the average normal adult. Respiration. How do you measure respiration? How do you measure your patient's respiration? Okay. So my chest rises and I say 1, and my chest falls and I say 2. Very good. So it's a cycle that we count. In and out. Can you see my chest rise and fall? Can you see it now? Okay, I am going to stand here as usual and continue to breathe so that I remain alive. And I would like you to count my respiration. What did you get? Who timed it? You timed it? I got 12. So you're pretty close. But remember, you have to have the clock. You have to figure out where you're starting. If you have a second hand, wherever you start, you're going to have it make 1 revolution to the same point and then stop counting. You cannot say to your patient, okay, I'm going to check your breathing. I'll tell you when to start. Because the patient cannot stop breathing. You have to be able to maneuver your measuring device and monitoring the patient's breathing at any time. Now, typically, do you normally say to your patient, I am going to check your breathing? Why don't we tell the patient? Very good, because until I started talking about breathing, none of you were conscious of your pattern of breathing or breathing in and out. It was just happening unconsciously. So the moment you start to focus on it, the patient changes their pattern of breathing, meaning you will not get their true respiratory rate. So typically, sometimes you may say to the patient, oh, I'm going to check your vital signs. And you would put your hand on the pulse, you're touching them, so they're going to be focused on the fact that you're actually making physical contact with their body. They're not paying attention to the fact that they're breathing. But you will be looking at their chest and counting their respiration before you start counting the pulse. Any questions? So what's the abnormal respiratory rate? Greater than 30 breaths per minute. If you count your patient's breathing and they're breathing at more than 30 per minute, it means something's wrong. And if you don't get help, what's going to happen to the patient? They can pass out, but sometimes they stop breathing. Do we know why? They get tired. Simple, in plain simple language, they get tired. those of you, if you've ever been around asthmatics who have a severe asthmatic attack, they actually just get tired. They're just breathing. Now, we have a lot of drugs in this country. So this is a side road that I'm taking. And there are certain drugs that patients take, and you may take their breathing, and they're breathing at like 9 or 6. What do you think they're on? You have patients that have it prescribed for them. What do you think they're on? An opioid. So they can suppress respiration when the patient overdoses. So you have to monitor that.